Can you still see it? Just give me a thumbs up. All right. So for some reason, the recording cut off. Technical difficulty seems to be the trend for the day. Introduction to diabetes, the endocrine system. Exocrine glands have localized effect, whereas endocrine glands have a systemic effect. Again, think epinephrine and fight or flight. Testosterone gives us big muscles everywhere as long as we work them. What in the hell? Can you still see it? All right. And hormones have specific targets. They can target specific tissues or specific organs. Again, epi is a good example. Alpha 1, alpha 2, beta 1, beta 2 receptors are affected heavily. Another big one that we're going to talk about a lot today is insulin. They target specific organs that insulin targets everything. It's a systemic effect. It helps the entire body absorb or utilize its sugar. And the endocrine system is used to regulate body function. So even if your endocrine system takes a crap, your nervous system doesn't work, you're going to get very sick and eventually die. It is essential for human life. So homeostasis, the natural tendency of the body to maintain appropriate internal environment in the face of changing external conditions. So when it's cold outside, your body generates more heat to keep you warm. When it's hot outside, your body can actually generate less heat, or it sweats to try to keep that body temperature down to maintain a moderate range of temperature. Metabolism is a cellular process that produces the energy and molecules needed for growth and repair. So we'll learn about that a lot more in sepsis. We start talking about acidosis. And later in this, when we start talking about DKA, acidosis is contrary to metabolism. We get acidosis when metabolism is not correct. We call it anaerobic metabolism. And what that does is our body doesn't produce as much ATP per cycle. And that the byproduct of that is lactic acid, which produces acidosis. Acidosis in any system, whether it be created by trauma, sepsis, or diabetes, is bad, and it's going to lead to death. All right, so 8 major endocrine glands: hypothalamus, pituitary gland, thyroid gland, parathyroid glands, thymus, pancreas, adrenal glands, and gonads. So we all know what the pancreas is. It's the one that creates and secretes insulin. Adrenal glands that makes adrenaline for fight or flight. Both pretty important. So body tissues that have endocrine function are kidneys, heart, placenta, parts of the digestive tract. So your heart doesn't just circulate blood, it actually helps with your endocrine system. So when we start having disorders of the endocrine system, we call that disease. One of the primary diseases that we deal with in an increasing obese public in our society is diabetes. We have type 1 and type 2. It's a deformity or disorder of the pancreas. Diabetes is often hereditary. Obesity does play a huge role. So even type 2 diabetes is starting to be linked to your genetics. That doesn't mean that because you have a certain gene pool that you're going to get type 2 diabetes, but if you add obesity on top of that genetic inclination for it, you're more likely to get it. Type 2 is very common, more common than type 1 anyways. 80% of cases of diabetes are type 2. And type 2 is also, you get lower extremes, so maybe you get less high extremes is a better way to say that. So your hyperglycemia and hypoglycemia aren't going to be as pronounced. Type 2 diabetics usually don't have to take insulin. If left untreated, your type 2 diabetes can progress to where you are insulin dependent. There's a lot of medications available now, and there's also this thing called exercise and diet control, which as I've gotten older, I've struggled with. So hopefully I won't have to go down that route of drugs. But I did go for a walk today, so go me. So usually dietary changes and increased exercise can sort it out. If not, they might upgrade to oral hypoglycemic agents, metformin, gabapentin. There's a bunch of other ones about to come out this year. Eventually, if untreated, leads to insulin dependency. So anytime we have a problem with the ability to access sugars, we have a concern of diabetic ketoacidosis. It's a serious, potentially life-threatening complication associated with type 1 diabetes. It is signified by extremely high blood sugars over a long period of time, a week or two. Usually is what happens is they are just not living a lifestyle where they're taking care of themselves, so they don't get their insulin shots. They continue to eat and or drink as normal, their blood sugar goes up. Over a long period of time, they get worse and worse. People that don't take care of themselves with diabetes or take care of their diabetes leads to insulin or a kidney failure. Kidney failure leads to dialysis. So very often, once they've started as a diabetic and led to kidney failure, they've led to dialysis, they continue to not take care of themselves. They don't lead healthy lifestyles. So again, DKA, diabetic ketoacidosis, is hyperglycemia exists because of lack of insulin. Body cells can't take in glucose, so they're eating normally, but their bodies can't access that glucose. Since they can't access the glucose, they look for energy elsewhere, and they do that by breaking down fat and muscle. The fat and muscle puts them into the anaerobic metabolism, avoiding that Krebs cycle. Krebs cycle is sugar and oxygen. The body goes into the anaerobic system where it's more can utilize the fat and the muscle. It's less efficient, and that means, and a major byproduct of anaerobic metabolism is lactic acid, and that leads to acidosis, the acidosis part of the ketoacidosis. The keto part is because your body's breaking down fat and muscle to get that energy, so ketoacidosis. These people, you'll see glucose in their urine. Back in the antiquity, when they were trying to learn what medicine was, I'm talking dark ages, doctors would actually taste urine or smell urine to see if it had sugar in it to help them determine what was going on. There was no treatment for it until insulin was found, and that's an interesting story I'll get into here in a second. So again, ketoacidosis is fat-based metabolism. It causes a rise in ketones. The ketones lead to a rise in acidosis. Polyuria, polydipsia, these people are going to be urinating a lot. They're going to be want to drink a lot. The skin's going to be dry and warm. Their mucosal membranes will be dry. It's a good thing that you can look in the field, have them smile, and look at their gums. If it's really dry looking, there might be a problem. Progressive sense of malaise. Malaise is a fancy way of saying they feel sickly. So they're not going to want to get up and do things, so they're going to take less care of themselves, and that propagates itself down a slippery slope until ambulance ends up there, and cardiac arrest usually ensues. So again, ketoacidosis develops major compensatory mechanism. My talker's working well today. Acidosis appears rapid, deep breathing pattern termed Kussmaul. So really deep in, really deep out, really fast. It's pretty obvious once they're in Kussmaul. Their breath is going to be fruity and acetone-like, and I'll guarantee you every one of us has been on scene at some time where we had a person who was kind of acting a little bit aggressive, kind of assholey. They maybe had that smell of alcohol in their breath, and we're just assuming that they're a drunk asshole. We might not treat them as well as we probably should with all our patients. Come to find out their blood sugar is 600 and they're actually going into DKA because they didn't know they were type 1 diabetic, and we're just being not very good medical practitioners. I would encourage you guys to always be nice to people. You never know where they're coming from. For Travis County SD1, we should always check a blood sugar. It should be part of our normal vital signs. Our protocol specifically state 2 sets of vital signs for all transports. So at least one of those has to have a blood sugar attached to it. Part of our assessment should document the fruity acetone-like smell. They do see a mental function decline. The brain is a big hog of sugar, and if it's not getting the sugar it needs, they start to see a decline in their mental status. Keep that in mind. That's where that aggression comes from. It's, anxiety and aggression comes from hypoxia until proven otherwise. In this case, we're kind of proving that it's coming from lack of sugar. And that's sometimes something we can treat, but if they're a diabetic and they don't have the insulin, us giving sugar is not going to help. So diabetic ketoacidosis, we need a good history. They're usually going to know, if not one of their family members are going to know. If they're in a car on the side of the road and they ran into a pole and nobody knows why, that blood sugar might tell you everything you need to know. These people are going to show really high blood sugars, not like hypoglycemia that's going to show low. Oftentimes, if they're getting bad enough in hyperglycemia and they're starting to show mental problems, they might fall into a category of not being able to protect their own airway. In contrast with the hypoglycemics, a hyperglycemic patient is not going to get better in the field. We might be able to push fluids for them to help, but we're probably not going to affect a change. Once they're unconscious from it, we're not going to affect a change. So taking their airway would not be inappropriate in any way whatsoever. Just do a good assessment and do good documentation. And always check for your medical alerts. Bracelets, I have personally not seen a ton of them in my career. I've talked to medics that find them all the time. Maybe they're just more diligent than I am.
Hey, TK.
Sir.
I've actually seen more stickers and vial of life in the refrigerators than I have bracelets or necklaces.
Oh, yeah. I keep one of those on my fridge, by the way, with my drugs. So, yeah, always it says here somewhere, refrigerator, check the refrigerator for their med list and their history. I just, for some reason, never got in the habit of doing that myself. But it's always a good thing to do. It's good practice. So blood sugar, man, it's such an easy thing to do. It's a little poke. Any of your EMTs or firefighters or volunteers can do it. Always maintain airway, breathing, and circulation. I'm going to pause for a second. ESD1, this is Thomas. Okay. The name, who's calling? And who are you with? And what's this regarding? Okay, can I give him a message and I'll have him call you back? I'll confirm that. Yeah, that is him. No, this is it. He's just not in today. My name's Thomas. Last name's Kinney. Kinney. All right. Thanks, man. Bye-bye. What's the downside of Fridays? I'm the only one in the office, which is also the upside of Fridays. All right, ABCs, fluid resuscitation. The best thing we can do for diabetic ketoacidosis in the field is going to be push fluids. If they are in renal failure, which a lot of them are, if they're not now, chronically, they might be acutely. So we need to be cautious with that fluid resuscitation. And all we're really doing is trying to dilute the sugar in the blood, increase circulation, and maybe even reduce some of the osmotic changes for the kidney, to give the kidneys a break. All right, so HHNK, which is hyperglycemic, hyperosmolar, non-ketotic acidosis, little bit less common, a little bit harder to figure out in the field. It's usually a patient that has type 2 diabetes, and so they've had a slightly lower high blood sugar than the DKA people. So they might be around the 300s for several weeks at a time. And over the long period of time with that slightly elevated blood sugar, they start to see some problems. So those of you that don't remember, hyperglycemic, hyperosmolar. Osmolarity is the water's ability to move back and forth. Different types of cells or molecules, rather, will dictate fluid moving back and forth. So if you take a bunch of sugar and you have a semi-permeable membrane, that sugar is going to force that water to come to it, to dilute it, so they have the same concentration. If that happens in the body where you have a bunch of sugar in your blood, it starts to draw fluid into the circulation, which causes the kidneys to cycle it out. So they get dehydrated, which actually causes their blood sugar to concentrations to increase a bit more. It leads to a lot of the similar signs and symptoms as DKA. It's unlikely in the field that if we get a blood sugar reading of 300, we're going to think HHNK. We're probably going to say DKA, got to go to the hospital. And we're not wrong for doing so. Again, IVs and fluid resuscitation maintain airway. These people usually aren't quite as acutely sick. They've been feeling bad for a while. And you can see on the bottom of the slide here, it says water intake's inadequate to replace lost fluid. So again, the osmolarity of the sugar in the blood is drawing water to it. The kidneys, because they sense that water increase in the circulation, start cycling it out. And they start peeing a lot, that polyuria again, and they're not drinking enough water to replace it. So they end up dehydrated. That increases the concentration of sugars and leads to the same problem, that downward spiral that you see with diabetics a lot. So it's also called a hyperosmolar hyperglycemic state. That's just a simpler way of saying it. It's all the same stuff. So this is usually in the elderly. People that are kind of getting obese and moving themselves into that type 2 diabetes might end up with this. Their body just basically slowly perverting their body's ability to create insulin or utilize that insulin over time. And so if they don't know that that's happening, they might end up in a hyperglycemic state and not realize it, especially for those of us that go to the doctor once a year and avoid it every other time. I do not know what's going on. I'm having technology issues. Am I still showing the slides? Or are they coming in and out?
Yeah, no, I'm still seeing the slides. Everything's good.
I'm having to click everything 4 times on this end. All right, so now we're going to move into a few other ones. These are hypoglycemic specifically. We see this a lot. Back in the days when we had D50 on our ambulances and everybody had it, giving a NAMPA D50 to a hypoglycemic was awesome because they went from, oh my God, do I need to intubate him, to, oh, I'm awake. Powers that be and maybe a little bit too aggressive treatment with D50 has led to D10, a little bit slower onset, a little bit less profound effects. Still cool though. Usually these people have taken their insulin. They've got to eat. They know they're diabetics. You always hear, well, I took the insulin, then I had to run out for an errand that came up and I didn't make it back in time. You can see it with people, usually slighter of build, where maybe if they don't eat enough that day, that their blood sugar slowly decreases to a point where they start having effects. Either way, the treatment's the same. We give them some sugar. If they're conscious and can control their own airway, we can give them oral sugar. We carry little packets. We can give them soda. Anytime you're doing that and you get them back to kind of more alert, you might want to give them a sandwich. The packets that we give is short chain sugars that act real quick. A sandwich is a little bit longer chains, gives them a little bit longer effect to level them out a little bit. And one of the big risks with hypoglycemia is that the brain uses a lot of sugar. It's the way it keeps working. And if it's not there to use, then they actually can start having some brain damage. It can actually cause some fluid shifts in the brain, which can lead to some encephalitises. So keep that in mind. And basically is all that means is that we don't need to dally to get that sugar in and get them conscious again. Dallying can be bad. The altered mental state that comes from hypoglycemia is because the brain doesn't have sugar. Again, I've kind of covered all this. You will see a diaphoresis. They'll be sweaty, maybe some pallor, so light, maybe some paleness, pale, cool diaphoretic. They can go into seizures and become comatose, and this can develop quickly. These people might have an alert bracelet if they're insulin dependent, but if they're just like the old grandma who's slight of build, they're just not eating enough and they slowly over time drops, they might not have a bracelet. So it doesn't change anything. We still do a good assessment and we still get a blood sugar with every first set of vital signs that we do. Determine blood glucose level. It says here on the bottom, if patient unconscious, start IV of normal saline and administer 50 to 100 milliliters, 50% dextrose. We use D10 here at TCSD1. Most people do now. D50 was causing osmotic changes. It was causing necrosis. IVs were getting pulled, and it was just causing more damage than was good. I personally have never had to give a full amp of D50. I've always done like a quarter, and maybe a third quarter, and they always come awake. Keep in mind if you're using D10 in the field, it does take longer to work. So you have to be just a little bit patient. It might give you time, get the IV, get the D10 going, get them in the ambulance, get on the road, so they can't try to refuse and go back into the same situation that they were in. Now here's our protocol 3:1. This covers hyperglycemia. Keep in mind it does have a 12 lead EKG. One of the reasons for that is the low lack of blood sugar and the acidosis can lead to cardiac problems. These people are usually sicker than just the diabetes, so again, lends itself to cardiac problems. They also take things like metformin, gabapentin, both of which can mask chest pain. So they might actually have an underlying cardiac problem. That being said, our 12 lead doesn't need to be done within 5 minutes like we do for our STEMIs. It does need to be done before you get to the hospital. Transit if possible. You can see here if the blood sugar level is below 60, you go to hypoglycemia if it's above 250. Hey Cap, I've got something in my car for you. A good sample history, find out what meds they take, find out what medical history, nausea, vomiting, polydipsia, polyuria. Any questions on all that? It's pretty straightforward, nothing really new. I have that taken right at about half an hour. So congratulations. Let's take about a 10-minute break and we'll do the next one.
Okay, sounds good.